So we're ready to go. With a little bit of feedback in the background, could I ask people to mute themselves? So probably the easiest way to do this is to save questions for the end. I'm sure you're hearing a lot of clicking here. Then I just typed *6 to mute your phones. There's also a mute button on if you're on your computer. There's a mute button on the app. Right. Okay. So thank you everyone for coming. I'm going to go ahead. There's still a little bit of feedback going on in the background, but I'll just forge on and hopefully people can hear okay. So as Matthew mentioned, my name is Susan Tupper. I'm a physiotherapist, and so my role with the Saskatoon Health Region is kind of a diverse one. I get to write policies and provide education to people. I get to do some research and plan programs and quality improvement initiatives. So one of the areas of quality improvement that we've been working on in Saskatchewan is with the bleeding disorders team. So I've been working with them over the last couple of years to try and improve how they manage pain with their clients, and have had the wonderful opportunity of doing a number of research projects with them. How is the sound for people? Because I'm getting a lot of screeching. Oh, am I the one screeching? You're not. Okay. All right. So today, I just wanted to start off with some disclosures. So I don't have any commercial affiliations with any organizations. I did receive a speaker honorarium from Bayer for this webinar, and I'd like to thank Bayer for sponsoring this event, because it's a great opportunity for me to meet with you, and I'm hoping that you'll find some interest in the topic that I'll be presenting on today. I do hold a research grant with the Canadian Hemophilia Society through the Noble No-Risk Psychosocial Research Program, and I want to remind people that if it does come across that I'm recommending a particular treatment and it feels like I'm speaking to your soul tonight, just keep in mind that everything that I'm talking about, I encourage you to take that to your healthcare providers who can tailor the advice for you. So I'm hoping that you'll be excited by what I'm talking about, but just keep in mind that there's no one treatment that is right for all people, and so you really need to use your discretion and seek some advice for treatment. All right. So tonight I'm going to be talking about the prevalence of chronic pain, both within the general population as well as within the bleeding disorder population. I'm going to be talking a little bit about some of the factors that can contribute to the development of chronic pain and why people with hemophilia or bleeding disorders are particularly at risk for development of chronic pain. We'll talk a little bit about the nervous system and how it modifies information that it receives to affect how pain presents. And we're also going to be talking from a treatment perspective. I'll talk about very generally about medications. Remember, I'm a physiotherapist, so no one should ever take medication advice from me. But I will be talking about medications and exercise, and I wanted to kind of show the parallels between the two of those and kind of how the two of them both work quite similarly to affect the nervous system and to affect chronic pain. So that's what I'll be talking about today. So I'm going to start off with some definitions. So pain has been defined by the International Association for the Study of Pain as the unpleasant sensory and emotional experience associated with actual or potential tissue damage. So a very generic definition for something that is quite a bit more complex than it would appear from this definition. The definition for chronic pain is basically pain that lasts for longer than we expect it to. And there's been an arbitrary time point of about 3 to 6 months for this. So there's nothing magical that happens between the 2nd month, 29th day, and the beginning of the 3rd month to suddenly switch pain from being one entity to being something completely different. Quite often, chronic pain is misunderstood as being emotionally related or psychological pain. You know, when it's acute, it's real pain. When it's, when it's chronic pain, it's not real pain. And that's a misunderstanding of what's actually happening. So we're moving away from this definition of chronic pain as being something different. I mean, in some ways it is different, but we're moving away from looking at the time as a definition of chronic pain and moving more towards looking at what are the underlying causes of pain that make it last for an unexpected period of time. So I just wanted you to be aware of that. Another problem with using that time-based definition for chronic pain is that it doesn't explain why the person still has pain, and it doesn't point to best treatment. It basically just says pain has lasted for a long time. So the new approach to talking about pain and what is now moving towards a new way of looking at treatment, oh, the sound is suddenly much better. So we're moving away from looking at chronic pain as being something related to time to looking at some of the underlying mechanisms. And there are basically 3 types of pain that I'll describe here just briefly. So the main type of pain, the most common underlying mechanism for pain or type of pain is nociceptive pain. So this is basically pain that arises when there's injury, disease, or infection, or the threat of injury to body tissues. So if there is something happening to your muscles, bones, joints, ligaments, viscera, your organs, then that can cause a signal to go to your nervous system, and it can cause pain that we call nociceptive pain. The nice thing about nociceptive pain is that it's fairly straightforward to treat, usually by treating the underlying pathology. The pain will resolve nicely, and it really does go on and off depending on what the signals are to the nerves and what's happening with the body tissues. So when the threat to the body tissue stops, the pain also stops. So it's a nice, fairly straightforward type of pain. The second type of pain, the next most common type, is neuropathic pain. And this is the type of pain that arises when there's injury, disease, or infection, specifically to a nerve. So this can be a nerve in the peripheral nervous system. So for example, shingles or a diabetic neuropathy that gives a person a pain in the hand or the foot. Those are examples of peripheral neuropathies. You can also get central nervous system neuropathic pain as well. So following a stroke, you can have pain in parts of your body, or a spinal cord injury. Those kinds of things can cause ongoing chronic pain as well because of the injury to the nerve. The third type of pain is a little bit different in that it is, we call it central sensitization. Sometimes it's called centralized pain or pain amplification syndromes. So this type of pain is a little bit unique in that it may not necessarily be related to any underlying pathology. It may begin secondary to an underlying pathology, but you can also get this type of pain that starts for no apparent reason as well. And this type of pain is due to chemical, structural, and functional changes in the nervous system that basically cause an increased sensitivity of the central nervous system. And we're going to talk a little bit more about this later on in the presentation. So those are the 3 overarching types of pain. And of course, pain never is simple. You can get, somebody can have more than one of these types of pain. For example, somebody who injures the low back, they may have inflammation in the muscles and joints causing a nociceptive pain from those muscles and joints. They may also have a bulged disc that pinches on a nerve that causes a neuropathic pain that runs down their leg. And then over time, because of what's happening in the nervous system, they can develop a central sensitization type of pain that even if the original injury, the inflammation in the muscles and the joints or the pinched nerve, that can even resolve, and you can still be left with this central sensitization that makes it feel like there's still that ongoing nociceptive or neuropathic pain happening in the back and down the leg. So you can have overlap between these types of pain. And also they can change over time. So you can start with one type and it can develop into another. So pain likes to keep us guessing, and so it gets kind of messy sometimes. So how common is chronic pain? It depends on the types of questions you ask. So, for example, this Canadian telephone survey was done with about 2,000 adults across Canada. So if you generally ask the question, do you consider yourself as suffering from pain? About 44% of people say yes to that question. If you narrow that down and say, have you had this for 6 months or more, about 35% of people say yes. If you require people to be suffering from this pain more than several times a week, then it's about a quarter of people. And then if you require them to have a moderate to severe intensity of pain several times a week or more for at least 6 months, it drops down to about 19% of the adult population. So, and of course, there's different demographics across the country. So this survey, the people in Ontario, it was about 17% of people had chronic pain. Out here in the Prairie provinces, it was about 20% of the population. So that probably reflects the aging demographics of people in Saskatchewan and people in the Atlantic provinces compared to Ontario, Quebec, and BC, where the rates of pain were a little bit lower. So 1 in 5 people, almost 20% of people, live with moderate to severe pain on a regular basis. So it's quite a large proportion of the population. Another telephone survey that was done in Alberta by their Alberta Health Quality Council, they surveyed about 5,000 people, and they found similar results, that about half of people said that they considered themselves as suffering from pain, but majority of people, they didn't have pain for a long period of time, or they didn't consider it to be a really severe condition, but about 3.4% of people said that they lived with an extreme problem with pain. And this is probably an underestimation of the number of people that are really severely debilitated by their pain, because of course telephone surveys are a little bit biased that way towards people who answer their phones. And it doesn't reveal people who live in long-term care homes, for example, or people who don't have the capacity to answer the phone. So as a conservative estimate, that's about 1.2 million Canadians that live with an extreme pain problem. We don't have the resources across our country, at least not currently, to address this problem. We don't have sufficient pain clinics for these people to get that ongoing care for their pain. So we need to be creative and think of creative ways where we can address this pain. So one of the ways that we're discussing out here in Saskatchewan is that people that come to the bleeding disorder clinic who live with this persistent pain might be able to get some increased advice around their pain from the bleeding disorder team in conjunction with ongoing care from their family doctor. So within the bleeding disorder population, the prevalence of chronic pain, unfortunately, is a lot higher than the general population. So here you see in this red bar here, that shows the general population of about 20%, 19-20% who live with chronic pain of moderate to severe intensity. A study of people in the UK, a UK patient registry with their Hemophilia Society, found that 78% of people had pain at least once a week, but 57% had daily pain. And this study was mostly men, and with an average age of almost 50 years old. So it probably reflects a more severely affected population, but that's quite a large proportion of people within the bleeding disorders community who live with regular pain. Another study that looked at younger people, so restricted the survey to people between the ages of 18 and 34 years, still found that about 28% of young people live with persistent pain. And they asked them to report if they had pain most of the time or all of the time. So higher than the general population. Within the von Willebrand's diseases, about 44% of people who have joint bleeds also report regular pain. And if they don't have joint bleeds, they have similar proportions of pain to kind of the general population of about 18%. So it looks like our prevalence of pain is related somewhat to joint bleeds. And that would reflect even the general population. The most common cause of chronic pain or underlying pathology that people attribute their pain to is arthritis. And so within the bleeding disorder population, of course, there's much higher rates of arthritic changes in the joints because of joint or muscle bleeds that affect the tissue health. So hemophilic arthropathies can develop with recurrent joint bleeds. So when there's a bleed, generally speaking, the synovium will bleed and you'll get blood into the joint, and the chemical changes that occur because of blood in the joint can set up these arthritic changes that affect the cartilage, the synovium, and the subchondral bone. So the subchondral bone is just the bone that lies underneath the cartilage in the joint, and so you can get changes in how the bone reforms. So our bones are constantly being resorbed and reforming and laying down new bone material to stay healthy and strong. And this balance gets altered because of the inflammation in the joint and the blood into the joint. So basically you get the resorption continues to happen, but the bone formation isn't happening at the same rate that it does in people who don't have bleeds into the joints. So what happens with this is that you get local osteoporosis, so a thinning of the bone in around the joint. You can also get little cysts or pockets of where the bone erodes. You can also get osteophytes, so you get changes in where the bone is being laid down. So osteophytes are basically bone spurs that grow in around the joint, and you get these little lips of extra bone growing. And you can get enlarged epiphyses, or the growth plates grow at a different rate. And so you can get changes in the shape of the joint as well. You can also get nerve injuries or neuropathies that develop when there's persistent inflammation in around the joint as well. And this is similar both for rheumatoid and osteoarthritis and for hemophilic arthropathies as well. And you can also get, if there's bleeds into the muscles and those don't resolve quickly, then you can get fibrosis or basically scarring in the muscles that can be laid down because of the hematomas into the muscle. So we have all these different tissue changes that can affect the health of the tissues and can contribute to development of pain. What's interesting though, so it's not really a question of why do people with bleeding disorders have pain. They've got lots of reasons to have pain. There's an estimate that about 90% of people, if they don't use prophylactic factor treatment, by the time they reach their 30s, about 90% of people with severe hemophilia And so because it's so unpleasant, it will motivate us to escape and to seek relief or to seek healing and recovery from whatever injury we've sustained, and basically to avoid doing what caused the pain in the first place. So those are kind of the two benefits of pain and the two fundamental purposes for pain. So there are a few different types of stimuli that will activate the system that leads to development of pain. So we'll talk about those for a moment. So the three main types of stimuli, number one is mechanical stimuli. So basically any pressure, strain, stretch, any distension of our tissues will activate special nerves called nociceptors. Another type of stimulus that will activate these nociceptors are chemical stimuli. So that can be inflammation in a joint or in a body tissue, but it can also be a chemical irritant on the skin as well. The third type of stimuli that will trigger activation of these nociceptors are thermal stimuli. So if our tissues get too hot or too cold, then these nociceptors will say, that's not good, that's not healthy, and you need to move. So all of these types of stimuli will activate nociceptors, which may or may not end in pain, because there's a lot of other factors that go into the consideration of whether pain is a useful motivator for escape and relief. So the nociception, the nerves that run from the majority of tissues in our body, those nociceptors run up to the spinal cord where they connect with other nerves in the spinal cord that run up to the brainstem and brain. When I say the nerves connect, basically the one nerve ends, the next nerve, there's a little gap between them called the synapse. The nerve that runs from the periphery releases little chemicals called neurotransmitters that very quickly transfer across that synapse, and those neurotransmitters will cause that electrical signal to go in the nerve that runs along the spinal cord, and then there's other synapses there where the nerve in the spinal cord connects with nerves in the brainstem, and more connections, more neurotransmitters, and that goes up to about 20 different areas of the brain that are involved with processing information that may relate to the development of pain. So that's one direction. Information comes from the periphery, runs to the central nervous system of the spinal cord, the brainstem, and the brain, and where it is integrated with a whole bunch of other information that the brain is constantly receiving. So other information from other sensory organs, what we see, what we hear, what we smell, but also areas of our brain that are responsible for recalling past events. You know, have I felt this before? What happened then? Do I need to worry about this? So the emotional parts of our brain as well, and the recall, the memory of past events. And within split seconds, this information is processed and may or may not result in production of pain. So at the same time that the brain is integrating the information from our periphery, the brain is also sending signals to our brainstem and our spinal cord to either increase the amount of information it's receiving from the nociceptors or to decrease that. So the brain and brainstem will tell the spinal cord, I want more of that information, so it'll facilitate that delivery of information from the nociceptors, or it will inhibit that information and it'll shut down and desensitize the information running along the spinal cord up to the brain and brainstem. So the nervous system runs in those two directions. Basically, the information comes from the periphery, but the brain with its processing will either say, yes, that's important information for me, or no, I don't want to hear that right now. So it will modify and modulate the information that it's receiving. So I'll give you some common examples that you've most likely experienced that show how our nervous system can modify and modulate information from the periphery. So here's some examples of increased sensitivity. Probably the last time you experienced having a cold or a flu, you may have ached all over. Even your hair may have ached, and your fingernails hurt. Even though they don't have nociceptors, it just feels like your whole body is just achy, stiff, and sore, and doesn't want to move. So when we have these generalized infections, colds and flus, our nervous system is just kind of more sensitive. And so it perceives information that shouldn't be painful, like touching your skin or moving your arm. It will perceive that as painful, even though there's not any harm or tissue damage happening in your areas that are moving. Another example is anxiety. So the more anxious and fearful we are, the more sensitive our nervous system is, and the more it is able to amplify or facilitate that information coming in from the periphery. So at the other end of the spectrum, we can have reduced sensitivity of our nervous system thanks to the activity of our brain and brainstem. So for example, anesthetics are an example. You go for a surgery and you receive an anesthetic, which blocks some of the transmission of the information from the peripheral nerves to the central nervous system, so that you can be cut open and have your organs rearranged and or your joint replaced, and you don't feel it, which is fantastic. Another example is an athlete in a competition or in a game. They can be pummeled. If you think of a quarterback being sacked during a football game, if that kind of activity happened outside of the football field, it would probably be a lot more painful than it is when they're in a game and where it's within the normal context of being part of the game. So our nervous systems modify and modulate information thanks to a whole host of different factors that allow that information to be modified. One of the key ways that this information is modified is by changes in the number and types of neurotransmitters that are basically communicating from one nerve to the next. So there's a number of other things that are happening as well, but changes in the amount of neurotransmitters is kind of one of the key things that affect sensitivity of the nerves and nervous system. So with chronic pain, one of the things that's happening is basically you get this a change in the balance, so that you get this increased sensitization along the nervous system. And again, this is not the only thing happening in chronic pain, or the only reason why people have chronic pain, but it's what we think is one of the primary reasons. So the nervous system, the central nervous system in particular, can become extremely sensitized, so that things that shouldn't hurt do hurt. And pain no longer becomes a useful warning signal. So a lot of the reason why that happens is because of genetic vulnerabilities. At least half of, they think, the genetic researchers think, that about half of the explanation for this increased level of sensitivity in some people is because of the genes that they have that affect the types and amounts of neurotransmitters that are being produced, and the amount of inflammation that's being produced as well. So some people are just genetically really great at causing chronic pain or developing chronic pain, unfortunately. So of course there's a lot of other factors that play into this, but part of it is our genes, our underlying genetic profile. So that may explain why, 90% of people with hemophilia, by the time they reach 30, if they haven't used prophylactic factor treatment, 90% of them have hemophilic arthropathies, but only about 57% of them live with regular pain. All right, so some of the changes that occur in the central nervous system to affect the sensitivity, of course, there's the chemical changes, so the changes in the types and amounts of neurotransmitters that are produced. So there are neurotransmitters that increase the amount of nociceptive signaling, substance P, glutamate, serotonin, 2A and 3A, nerve growth factor, and then there are other neurotransmitters that inhibit or reduce the sensitivity of the nervous system. So you get a change in the balance of these neurotransmitters that can create chemical changes in the nervous system that increase the sensitivity for people who live with chronic pain. There are also structural changes, so you can get changes in the types of inhibitory interneurons in the spinal cord that are one of the brakes on the system. And the third change is that you get changes in the way the brain talks to itself. Basically, the different areas of the brain communicate with one another, so you get changes in the connectivity of areas of the brain that are responsible for producing pain. So there's a few different things that are happening, and so there's a lot of new, interesting research that's happening in this area to try and better understand what some of these things are and whether they're reversible or not. So another reason why people with bleeding disorders may have increased prevalence of chronic pain is because of the amount of exposure to pain that they have over their lifetime. So the more you're exposed to painful events, then the more likely you are to develop that central nervous system sensitivity. So one of the things that I've noticed in the past couple of years of working with the bleeding disorder team is some of the beliefs around pain, particularly that men with severe hemophilia have. And these beliefs can lead to delays in treatment or under-treatment of pain. So for example, and some of these beliefs may be common for some of you in the audience as well, but people who've lived with pain for 40 years are kind of like, why should I bother complaining about it now? Or I've tried treating it, nothing seems to work, or you know what, I'm just going to wait until things are really unbearable, or I can't stand it anymore before I seek treatment for my pain. Or there may be fears around addiction to some of the treatments, or the perception that the only treatment is medications, which isn't true. So some of those beliefs may lead people with pain who live with a bleeding disorder, it may lead them to delay getting treatment for their pain, or basically just to undertreat their pain. And that undertreatment of pain can sensitize the nervous system so that it becomes harder to treat the pain, basically. Another thing about bleeding disorders is that, particularly for people with severe hemophilia, they may have been experiencing pain since let's say were young children as well, having bleeds into their muscles or joints. Of course, needles with infusions or blood draws to monitor the course of the disease. People with bleeding disorders may have had multiple surgeries, and rehabilitative therapies as well. So the stretching or the exercises that the physiotherapist gives can also be painful, and all of that contributes to basically the load, the pain load that is being, the spinal cord and brainstem and brain are being exposed to, and that can sensitize the nervous system a little bit more. So we've talked about genetic vulnerabilities. So some people have genes that predispose them to development of chronic pain. So for example, 2 people get into a car accident or 2 people go for the same surgery. The person who has that genetic profile that basically increases the amount of nociception, they will be the one that develops chronic pain, whereas the person who doesn't have that genetic profile will not develop chronic pain, even though they have the same injury or the same disease. So so far, I don't believe that there's been any, I'm not aware of any research that has looked at whether people with bleeding disorders are more likely to have those genetic vulnerabilities. I can't imagine that that would be the case, but we don't know. That research hasn't been done yet. And we've also talked about the physical vulnerabilities that put people with bleeding disorders at risk of development of chronic pain, so the arthropathies and muscle fibrosis that can occur. And of course, the regular pain experiences throughout the lifetime, particularly exposure to pain in childhood, predisposes that nervous system to develop that sensitization. The fourth thing that is interesting to think about as well are psychological vulnerabilities. So people who have been exposed to trauma, particularly in childhood, or chronic stress throughout their lifetime, or people with anxiety or mood disorders are more likely to develop chronic pain. This may be because of some of the genetic vulnerabilities that we've already described, and there may be some common neurotransmitters that are present with chronic pain that are also present with some of the mood and anxiety disorders. But some of those psychological vulnerabilities are things that people with bleeding disorders experience. So, you know, particularly for men with severe hemophilia who were exposed to tainted blood in the 1980s, but even just living with chronic stress of having to manage a chronic condition like this, sure it is a chronic stressor for them that can basically contribute to that sensitization of the nervous system as well. So we have to think of kind of the with some care and some monitoring of what's happening with the risk of bleeds as well. Another thing to point out too is that some of these medications work better for nociceptive pain, others work better for neuropathic or central sensitization types of pain, and so you have to match the type of pain with the right type of medication and then monitor the progress. So unfortunately, sometimes if there's not a lot of knowledge around the types of medications or the type of pain, there hasn't been a lot of work to go into identifying what type of pain someone has, or you just assume that the pain is an inflammatory, nociceptive type of pain, the prescriber may rely on a certain type of medication and not really explore whether some of these other types may help with the type of pain that the person has. So it's important to get some good advice on what type of pain you have and whether the medications that you're on are appropriate for the type of pain. So of course pharmacists and physicians, pain physicians in particular, are well versed in this and can provide that advice. All right, I wanted to highlight a couple of sources of evidence that you can take a look at. So a couple of years ago, I asked the Canadian Agency for Drugs and Technologies in Health, or CADTH, to conduct a couple of literature reviews for me. So I asked them to search the evidence that was published on treatments, pharmacologic treatments for pain for people with bleeding disorders and non-pharmacologic treatments for pain for people with bleeding disorders. So the easiest way for you to find these reviews, and they're both about 5 pages long, the easiest way is to go to cadth.ca and just search for hemophilia pain, and those two reviews will pop up within the top few, and then they'll give you a link to the documents that you can read. So it describes the types of studies that have been done, and it summarizes the findings from these studies, and some of them are randomized control trials, and others are other types of trials. So it summarizes the literature for you and then kind of goes through the pros and cons of the different types of medications. And again, there are far more classes of medications than those that have been studied and those that have been reviewed in this review. So it's not to say that if the research isn't there, it's not to say that those treatments aren't effective. It just shows that we haven't done the research on those types of medications. So there's a lot more work that needs to be done to explore what the most effective pain treatments are pharmacologically and non-pharmacologically for people with bleeding disorders. I also wanted to highlight, because this is brand new out, just May 8th, the new Canadian opioid guidelines were released, and I've given you here the link to the document there, or to a web page where the document is housed with some other educational materials as well. So these new opioid guidelines, just fresh out, there are 10 different recommendations that have come from the expert panel that produced this guideline. And I think it's interesting to show that their very first recommendation of the new opioid guidelines is don't use opioids if you can avoid it, which I think is quite interesting. So basically the first recommendation is to try and optimize use of non-opioid medications, but also maximize use of non-pharmacologic therapies first, rather than use a trial of opioids. And again, this is highlighting, this is for chronic non-cancer pain. So these guidelines are not applicable to acute pain, and they're not applicable to cancer pain or palliative pain, end-of-life pain. So they're just for people with chronic non-cancer pain. So optimizing non-opioid medications and non-pharmacologic therapies first. Then they say the second recommendation is that a short trial of opioids may be appropriate if the other therapies have been ineffective, but there's a number of caveats to that recommendation of who may or may not be appropriate. So it's an interesting read to go through the recommendations. The third recommendation is if someone has an active substance use disorder, that opioids shouldn't be used because they present a risk for addiction. And the 10th recommendation is that if someone is on opioids and they're trying to taper them down and they're having challenges with that, that this individual should be referred to a multidisciplinary treatment program. So those are interesting guidelines to read through and just see what the expert panel recommended, and to think about how that might apply to you, and to discuss that with your healthcare team and make some decisions for your care. I also wanted to highlight a report that came out last November, I think it was. So that there's a lot of discussion coming around lately around cannabis, and particularly cannabis for pain. Now this document is related to the legalization of cannabis. It does talk about medical cannabis use, but it also talks about legalization for other purposes as well, and the regulation of how that's going to be monitored in our country. So lots of interesting discussion around this and kind of the parameters around it. I've given you the link for this document. So generally speaking, cannabis or medical marijuana for pain relief, there is some evidence in the general population that cannabis can provide pain relief, particularly for neuropathic and central sensitization pain, but also inflammatory pain conditions like rheumatoid arthritis, things like fibromyalgia as well. But it also it improves pain, but it also improves sleep as well. I wanted to highlight, though, that cannabis is not without its harms, or potential harms at least. So some people think that, you know, it's a plant-based product, and so therefore it's natural and therefore it's safe. And that's not true. It does have properties that can affect the central nervous system. And so some of the adverse events that have been reported are dizziness and drowsiness and cognitive effects. It can also impair people's coordination. For the smoked varieties of cannabis, it can contribute to cough or chronic bronchitis. It can also cause some cardiovascular effects with changes in blood pressure and heart racing, so the tachycardia, or the palpitations of the heart as well. And there's a number of other adverse events that have been reported in the variety of studies that have been done. So that's kind of within the general population or general chronic pain population. That's what has been reported. But I did want to highlight that so far there are no studies that have been done within the bleeding disorders population on the use of cannabis for pain control. I did find one study, an animal study with a rat model, but again, it was not a hemophilia animal model. I believe it was an obese rat model. And they found that there's 3 main types of cannabinoids, and so 2 of those, THC and CBN, both inhibited the thrombin-induced clot formation in vitro, so in a petri dish, basically. In live animals, THC and CBN both reduced or slowed down clotting times. So sorry, not reduced, they slowed the clotting time so that they took 1.5 to 2 times longer in the group that received cannabinoids than the control group. So just some cautions around that. Not to say that cannabis may not be an effective treatment for pain relief in people with bleeding disorders, but we just don't have the research to know the efficacy or the safety of this. So if this is something that your healthcare provider is recommending for you, then you need to please make sure that you're monitoring carefully. I also strongly recommend, even though cannabis can be obtained not through legal means, and it's fairly easy to obtain, so I'm told, I do highly recommend that people go through their healthcare providers so that they get the appropriate monitoring, and they can work with the healthcare providers to just balance what other medications they're taking, because there are some risks with combining cannabis with some of the other medications that people may be taking. So you need to make sure that it is being considered a treatment option with an understanding of all the other treatments that are being received. So again, not to say it's not effective, we don't know, but people need to be cautious with cannabis, even though it is a plant. All right, so where we're moving with pain management is to try and better understand some of the underlying mechanisms that are contributing to how the nervous system functions. And so hopefully within the next 10 years, we're going to see better assessment approaches and better treatments as well that are more targeted to an individual and the type of pain they have and the types of underlying mechanisms that are contributing to the pain. So again, this parallels some of the personalized medicine work that's happening within the bleeding disorders community around the factor infusions and how frequently those should be done. So it's an interesting parallel I thought I would point out. But it's early days yet for this, and hopefully that will change within the next decade. All right, let's go on and talk about exercise, which is one of, next to pain, is one of my favorite topics. So exercise for chronic pain. There have been hundreds and hundreds of randomized control trials looking at the effect of exercise on a variety of painful conditions, so everything from arthritis to fibromyalgia to migraines to everything in between. So generally speaking, the majority of people in these trials, and again, not every trial shows clear benefits, but the majority of trials show benefits regardless of the type of pain condition that someone has. So they can have an inflammatory or a degenerative musculoskeletal condition, a nociceptive type of pain, or a neuropathic pain, or central sensitization. So all the different types of pain and combinations of the 3 seem to benefit from regular participation in exercise. So the types of benefits, and of course these will probably be familiar to people. Of course you get the general health and well-being benefits and reduction in risk of diseases like cancers and obesity and arthritis. But you also get reductions in pain and improvement in physical function, sleep quality, cognitive function, quality of life, independence, and mood benefits as well. So lots of diverse, broad benefits from participating in exercise. So let's talk a little bit about why that is. First of all, let's talk about the evidence for exercise for people with bleeding disorders. So this Cochrane review that was done by Karen Strike and her colleagues that was published last year is an excellent review of kind of the key studies on exercise for people with hemophilia. So what the Cochrane review is, a very rigorous type of systematic review. And a systematic review is a type of study where the researchers kind of pull together, they screen all of the published studies that have been done on a topic, and they kind of sort through them and screen through for the really the best evidence. And they try to pool the evidence and see overall with all of these studies what is the consensus of these reviews. So it's kind of considered the top level of evidence for summarizing research. So the main findings, they ended up only being able to include 8 studies that met their criteria for inclusion in this review. So only a total of 233 men that were in the study, and they ranged in age from 8 to 49 years. So quite a diverse group that was included in all of these 8 studies, and it included people with hemophilia A and B. Again, each of the 8 studies had kind of a different protocol for the exercise, and so the interventions varied quite a bit, and the interventions were compared to quite different comparator groups. Some compared exercise to nothing, some compared exercise to a non-exercise control group, and so there were a lot of variabilities, and other ones compared exercise to one type of exercise to another. So lots of differences in how the studies were conducted. They ranged in duration, so people exercised for 4 weeks all the way through to 12 weeks. And the types of exercises were different as well. Some included anaerobic, dynamic, or isometric strengthening exercises. Others included aerobic exercises like cycling or running or walking on a treadmill. Some were water-based exercises as well. So none of the studies reported adverse events, which isn't to say that there were no adverse events. It's just what they were monitoring didn't show up, or you know, they may not have monitored all the types of potential adverse events, so some adverse events may have been missed. There were no reports on the effect of exercise on bleed frequency, so I thought that was kind of interesting as well. However, overall, among these 8 studies, there were positive outcomes from exercise compared to all the other comparator groups. So the benefits were in pain as well as joint health. So exercise improved the health of joints, improved range of motion, balance, and walking, and tolerance and muscle strength. So some of the fitness factors as well. So just some cautions that you should be aware of, that some of the studies included prophylactic factor treatment as a component of the intervention. So they had people use prophylactic factor treatment before they exercised, which potentially would reduce any adverse events related to exercise in terms of bleed frequency. Other studies limited the enrollment to just people with severe hemophilia, and others limited to just people with mild or moderate hemophilia. So there wasn't a lot of consistency in how the studies were produced or were done. And so because of that, it's difficult to come up with really firm conclusions on this is what's going to happen if you exercise. And again, you know, you always get a lot of variability. Some people respond in the typical way, and other people respond at either end of the extremes as well. So, but generally speaking, exercise for hemophilia appears to be a beneficial thing for people. All right, so let's talk a little bit about pain. So, I mean, it's understandable when you exercise that your muscles get stronger, your joints will become more flexible if you're stretching them, but why does pain change? While you're exercising and for a short period of time afterwards, where your nervous system becomes less sensitive to pain. So you're protected against pain when you're exercising. So the title for this, of course, we like to make big titles. The title is Exercise-Induced Hypoalgesia, hypo meaning less and algesia meaning pain sensitivity. So basically, if you live with chronic pain, your pain goes down, or if you test pain thresholds, you're less sensitive to painful stimuli. And typically, this is a 20 to 50% decrease in pain or pain sensitivity. And there's a number of different protocols that have been used to demonstrate this. So aerobic exercise for about 5 minutes, not a long period of time, at about 70% of the maximum aerobic capacity. So huffing and puffing, but not exhausted with that for 5 minutes. And you'll get about 30 minutes after you exercise of kind of this protection against pain. And then it kind of, the effect diminishes after that. You also get this effect with resistance exercise. So you get with about a 3-minute isometric contraction, which means you're holding a contraction with your elbow flexion or with even with the grip, only at about 25% of your maximum contraction capacity, and you'll get this exercise-induced hypoalgesia, but it only lasts for a few minutes after a resistance exercise. So different types of exercise will elicit this response, and but again, it only lasts for a brief period of time, usually while you're exercising and then for a brief period of time after you've done. So what is causing this? So this exercise-induced hypoalgesia effect, the mechanism that has been most often studied is your body's own production of opioids or morphine. There's a number of different types of opioids, but you may have heard the term endorphins. So your body produces its own opioids. It has its own system of receptors throughout the tissues that respond to the body's own production of opioids. And basically that's how the opioids that you take, the morphine or the fentanyl patch or Dilaudid, whatever type of opioid medication that you're taking orally, works on your body's own system of opioid receptors. And that's how those medications work. So when you exercise, your body produces its own endorphins or its own opioids that help to reduce pain and pain sensitivity while you're exercising. But that's not the only thing. So what they found is that you can block this EIH response by giving someone an opioid blocker, so an antagonist, so the things like naloxone that block opioid receptors can block this exercise-induced hypoalgesia effect. But with certain types of exercise programs, you can't reduce all of it by giving somebody naloxone. So there are other mechanisms at play, and the ones that have been found so far are endocannabinoids. So yes, your body produces its own heroin or morphine, opioids, but it also produces its own endocannabinoids or cannabis. So yes, we've got quite fantastic systems within our body. And again, the cannabis medication that you might take works on your body's own system of receptors, and that's how it works. But again, exercise produces endocannabinoids. With exercise, you also get an inflammatory response. So when our muscles contract, contracting skeletal muscle, you get production of a protein called interleukin 6, or IL-6. So this is a pro-inflammatory protein or pro-inflammatory cytokine that is an inflammatory protein, but it's one of those ones that your muscles contract, the IL-6 distributes itself throughout your body, and it sets up, it helps to initiate the release of anti-inflammatory proteins throughout your body that basically wherever you started with, you get this spike in inflammation with exercise, but then it reduces down to a level that's lower than the amount of inflammation you had in your body before you started exercising. So you get this brief period of increased inflammation followed by reduced inflammation throughout your body when you exercise. And so after you exercise, you have this longer period of time where you have an increase in the anti-inflammatory cytokines that are being circulated throughout your body. Another thing that happens when you exercise is that you get changes in those neurotransmitters that modulate nociception. So nerve growth factor, brain-derived neurotrophic factor, basically the ones that sensitize your nervous system, you get less of those being produced. The ones that calm down your nervous system, you get an increase in those being produced. So the whole balance of neurotransmitters shifts somewhat while you're exercising to basically reduce the sensitivity of the nervous system. So if you could think about an optimal polypharmaceutical cocktail that you could create for somebody who has pain, you might throw in some opioids and some cannabis and some anti-inflammatories and some medications that settle down the sensitivity of the nervous system, like antidepressants or anticonvulsants. So you could put those all together and give those to somebody to manage their pain, but you also get this when you exercise for a short period of time. So there are some interesting parallels between the medications that we take and the exercise that we do that affect pain. Over the long term, you get changes in the genes that basically that produce or code for the production of neurotransmitters that affect the sensitivity of the nervous system, as well as genes that affect inflammation. So if you are a regular exerciser, over the long term, your body will change its genetic expression, basically, so that you are producing more anti-inflammatory cytokines, less of the pro-inflammatory cytokines, and you're producing more of the neurotransmitters that calm down the nervous system and less of the neurotransmitters that sensitize or amplify nociceptive signaling. So you get this fantastic shift when you're a long-term exerciser to settle down the sensitivity of the nervous system. So some exciting newer research that's coming out around biomarkers or changes in genes related to exercise, or the epigenetic effects of exercise. All right. Also, when you exercise, generally speaking, if you're exercising frequently, at least 3 times a week, you may get some weight loss, so some reduction in that visceral fat mass. So the visceral fat mass is responsible for producing about 1/3 of our pro-inflammatory cytokines. So when you lose weight, particularly around your abdominal girth, you get a reduction in those pro-inflammatory cytokines, and you also get an increase in the anti-inflammatory cytokines that are being circulated as well. So the combination of the effects on genes affecting neurotransmitters and inflammation, and kind of a reduction in that low-grade systemic inflammation, both of those can have impacts on pain. So it's important to keep in mind, though, that not everyone benefits from exercise. So, you know, it's not a panacea for all things negative in the world, although, you know, you talk to some physiotherapists like me, you might believe that it is the cure-all for all bad things. But anyway, not everybody responds positively to it. So here's a study that demonstrates that. So this was a study where people with chronic low back pain, again, not a bleeding disorder population, chronic low back pain group, had 7 tailored physiotherapy exercise sessions. At the end of the 7 sessions, and these people were encouraged to exercise, they attended physiotherapy once a week for 7 weeks, and they were encouraged to exercise at least 3 times a week in between sessions. So at the end of the 7 weeks, 59% of people had a significant reduction in pain and an improvement in function. So that's still 41% of people that went through the same thing but didn't have much of a benefit from it at all. And then they followed these groups up a year later and basically encouraged people, please try and keep exercising, but they didn't request or require that people continue to exercise. They just let them do whatever they wanted to and then followed them up a year later. So of the group that were initially responders at the beginning, the majority of them maintained that benefit, but about 38% of them lost the benefit that they had originally obtained after the 7 physiotherapy sessions. Similarly, The people that were non-responders at the beginning, a year later, still the majority of them were still non-responders a year later, but there was a group of them that actually flipped over and they did have a significant reduction in their pain, more so than the control groups. So what they found is that the people who had better baseline mental health and they were younger or had lower baseline pain scores were more likely to be responders or have that significant improvement in their pain with the exercise. But the main key thing was that exercise adherence predicted whether somebody was a responder or not. So the people that were more likely to exercise while they were taking part in the 7 sessions and the people that maintained their exercise participation throughout the year, they were the ones that were more likely to get the benefits from the exercise and show reduction in pain. So exercise doesn't benefit everyone, particularly if you don't do it. How's that for a stunning statement of the year? All right, so let's talk a little bit about how much exercise is required to get those benefits. First of all, we need to define what exercise is. So basically, exercise is a physical activity that increases your heart and breathing rates. That's a pretty basic definition. What the Public Health Agency of Canada recommends is that people get at least, or adults get at least 150 minutes per week of moderate to vigorous intensity exercise. So again, exercise that increases your heart and breathing rates. So that's about 30 minutes, 5 days a week. And the exercise doesn't need to all be done all in one bout. You can do it in 10-minute bouts several times throughout the day. And they also recommend that people get strengthening exercises at least 2 days a week and also take part in flexibility or balance exercises if they need improvement in those areas as well. So those are the recommendations of the Public Health Agency of Canada saying if you do this amount of exercise, you're going to have these general health benefits. You're going to be less at risk of obesity, heart disease, cancers, etc. So that's for general health benefits. For pain, however, it looks like you don't even need to do that much in order to get the benefits. So that list of studies that I had put up earlier showing all the improvements in people with chronic pain who exercise, the majority of those studies do not have people exercising at this amount, at 150 minutes a week. Some of them have people exercising twice a week or once a week. Some of them have them going 5 times a week. And some of them just have them doing light exercise. But generally speaking, regardless of the type of movement or how intense it is or how often you do it, people get benefits. Now, when lower levels of exercise are compared to more exercise wins out. So the more you do it, the more benefit you're going to get. But you know, it may be an impossible goal or seem like an impossible goal if you're not currently exercising and you have a lot of pain. You may think 150 minutes a week, there's no way that I'm going to be able to do that. And that's okay, because you don't need to start there. You can work towards that goal, but basically it's just starting at interrupting your sedentary time and then gradually building to the point where you can do 10 minutes of exercise, of light exercise, and then building up to 10 minutes of moderate to vigorous exercise and then adding to that time. So you gradually, and it may take months for you to get up to 150 minutes a week, but that's okay because you can still get the benefits of even less exercise and just interrupting the time that you're sitting or lying down. All right, so there are many challenges for people in beginning and maintaining an exercise program, and people who live with chronic pain have additional barriers of pain and fatigue and occasional joint flares. So it's important to keep some thoughts in mind as you're thinking about beginning an exercise program. First off, talk to your treatment team and see whether you are the type of person who should be starting an exercise program. Talk to your family physician as well and say, you know, given my health conditions, is it okay for me to exercise? The majority of healthcare providers will say yes and then give you some tailored advice. It's a fairly rare occasion when somebody shouldn't be exercising. And of course there are health conditions where you should not be exercising, so just keep that in mind that you get some advice, particularly if you haven't been active for a while. You need to get advice on that, particular to your health conditions. So it's important to plan for pain management while you're exercising and for the period of time after you're exercising. So yes, our bodies produces exercise-induced hypoalgesia, but remember that only lasts for a short period of time, and not everybody gets that response. So particularly if your nervous system is more sensitive, you're not going to get that exercise-induced hypoalgesia response. People with chronic pain, probably about a third of people with chronic pain have a normal exercise-induced hypoalgesia response. A third of people don't get any benefit, and a third of people actually feel worse when they exercise, and their nervous system gets more sensitive for a period of time. So you need to plan how you're going to manage your pain while you're exercising. So medications may play a role. So you need to talk to your family doctor or your bleeding disorder team and get some advice on whether there are some medications that you can take while you're exercising, just to get you through that initial point where it's uncomfortable and where you start to get the benefits of the pain relief with exercise. There are many psychological coping strategies as well, so deep breathing and mindfulness are a couple of examples of things that people can do while they're exercising and afterwards to minimize some of the discomfort that may be happening. Even basic distraction, right? So if you're on a recline bike and you've got your playlist of music playing through your phone or you're on the TV or something like that, then that distraction can help to reduce some of the discomfort related to the exercise. There are also physical strategies like using cold packs or compression bandages or splints or braces that can help protect your joints as well. Or things like transcutaneous electrical nerve stimulation, devices that put a little electrical signal into your nerves that helps to block some of the nociceptive signaling. So for some of these strategies, you can talk to your physios and get some specific advice on what might work for you. So you should also plan gradual progressions and a gradual build-up of your exercise tolerance. You don't want to think, okay, exercise is good for me, I'm going to just go out and do it, and I'm going to do what I did when I was 20. That's not good, because that will probably cause an injury. So you want to build up very slowly and gradually. And so you're building up your strength and your flexibility, and know what your limits are. Pay good close attention, particularly in the beginning, well, really all the way through your exercise. Pay attention to what your body is telling you. Keep in mind that all movement is good. You don't need to push yourself to the extremes. You can be happy with just doing a moderate level of exercise instead of thinking that the only good exercise is to take the next sweat. That's not true. All movement is good. And you should also talk with your treatment team to see if you should be taking prophylactic factor in order to prevent a bleed with the exercise. There's also some thought too around, really aggressive or compressive exercises, ones that have, jogging and things that are jarring for the joints may not be the best for people who have frequent joint bleeds. So again, talk to your treatment team about that and see what types of exercise are recommended for you. Good advice though is you need to do something that you enjoy. So that's kind of the first key thing, but making sure that hopefully you can get a range of different strategies and enjoy things that are safe for your joints as well. You also need to prepare for relapses as well. So you need to have a contingency plan so that you can continue exercising if you get a bleed or a flare of your arthropathy pain. So what I mean by that is that if you have a bleed in your knee, for example, or your ankle, you may need to change your exercise program so you give that joint time to rest, but you still are able to maintain some amount of exercise in the rest of your body. And again, you may need some specific advice from your treatment team on this. So here's my example is I really enjoy doing yoga. However, if I get a head cold and my sinuses are all stuffed up, I don't like bending forward with yoga. So, because that just makes your head feel like it's going to explode. So if I get a head cold, then I need to do something else. I need to go for a walk, or I need to change the yoga practice so that my head doesn't tip down and give me a headache. So you need to think of ways that you can modify things so that if you do come into these, encounter these barriers of having a bleed or having a flare, that it doesn't shut you down for 2 weeks, that you still maintain some level of exercise, knowing that, you don't need to exercise your joint that has the arthropathy in it in order to get benefits throughout your whole body that will reduce your pain. So there are times, or there may be times, when exercise just isn't possible. For example, if you're recovering from a surgery and you need your energy reserves to help with healing, you may need to do something else instead that will help to settle down your nervous system. So some of those psychological strategies of mindfulness or graded motor imagery, things like that, can be helpful to settle down the nervous system when you can't exercise. But always try to build in a plan for return of going back to exercising again. If you've been away from it for several days or several weeks, you don't want to jump in at the level that you stopped at. You want to back things off and gradually build up again so that you can progress and return to exercise safely. All right, so I've included a list of a number of different resources if you want to learn more about pain management in general. So the Pain BC website is fantastic and has so many great resources and information for people who live with pain. And Pain Australia, similarly, Canadian Pain Coalition. And I also wanted to put in a plug for the website that I have here with the Saskatoon Health Region. So we talk, on this I talk generally about pain management and talk about the resources available here if you're ever visiting Saskatchewan. And also have a web page of resources and research that has links to books and web pages and other websites where you can get more information as well. And there's a brief video, Understanding Pain in Less Than 5 Minutes, so you can just Google that, find that video on YouTube. And it's 5 minutes, and it's kind of one of those cartoon drawings that explains chronic pain and some of the strategies for coping with it. So it's a nice little short snapshot on chronic pain. All right, so to summarize, pain in hemophilia seems to be quite common and bothersome. It interferes with quality of life and employment and physical activity for people who live with this. And this pain with hemophilia may be related to changes in the muscle, joint, and bones, but it's also related to changes in the nervous system sensitivity as well. The good news is, though, that nervous system sensitivity and joint health actually respond positively to exercise. So just because you have the arthropathy doesn't mean that you're doomed to a life of chronic pain. It responds, our bodies respond positively when we give them these positive stresses like exercise. So both medications and exercise have parallels in how they reduce pain by altering the body's production of neurotransmitters and inflammatory proteins. And so it's important to work with your treatment team to try and develop a tailored plan, pain management plan. And here's my plug for exercise again. Try to include some exercise because it seems to be helpful for the majority of people. All right. So that is the end of my talk, and I would like to open it up now to people's questions. And so I believe it would be good for people to unmute their mutations. What's the right word for that? Unmute things, and so we can begin to ask questions, and hopefully I'll be able to find your questions here.
If you've got a question, you can go ahead and chat. Use the chat box to type it. If you're not able to unmute,
I see one question there. I can read this one question here. So the question is, I often feel better during exercise, but stiffen up and feel awful 60 minutes or so after. And I know I need to keep everything moving, but the pain after is somewhat a deterrent. So that's true. So that's a very common experience. So you're describing perfectly that exercise-induced hypoalgesia. So it's fantastic that you're getting that response. That things feel good while you're moving, but then you get that kind of that after effect, where you may be still in that phase where you have the increased pro-inflammatory cytokines that are kicking up that inflammatory response, and you haven't yet gotten into the phase where you have those anti-inflammatory cytokines kicking up. So there's kind of this timing fluctuation where things might feel worse for a bit. So you can try a few different things. So part of it may be just modifying your exercise regimen to see if you can adapt it somewhat so you don't quite have so much discomfort afterwards. You can also time your pain relief as well. So again, I listed a number of common strategies of medications or psychological or physical strategies to manage pain. So you can look at trying some of those strategies after you're finished exercising just to see if that kind of eases some of that discomfort as well. So again, I encourage you to talk to your family doctor or talk to your treatment team and see if they can provide some specific advice for you, because I can't, not knowing you or not being able to assess you, I can't give you that advice over the webinar, but that's one of the things that you can do. So two things you can do. Number one, see if you can modify your exercise program so you don't get quite that negative kickback effect afterwards. And number two, trying to add some preventative pain treatment after you exercise. So hopefully that answered your question. Keep in mind too that as you continue to exercise, that will change over time. So for the first little bit of doing an exercise program, you'll have more of that, where you have more discomfort after you exercise. And typically people that I work with say that it's more extreme within the first 2 weeks of starting an exercise program, and then it kind of tapers off somewhat, where you get more of the pain relief and less of that kickback effect afterwards. And then gradually, as you build up your exercise tolerance, you'll have less of that as well. So I encourage you to keep going, but try and manage the pain or adapt things if you can to try and reduce that negative effect. Okay, I think there's another one here. So the next question is, how do I get my heart rate up with 2 badly damaged ankles, a fused knee, and a badly damaged elbow? Excellent question. Yeah, that's a tricky one. Yeah, because it sounds like you're wanting advice on what mode of exercise to do that won't place any stress on your ankles. Some people benefit from water-based exercises or resistance bands, things like that can be used. Again, it's hard for me to give you specific exercise advice over the webinar, not knowing you. So you talk to your treatment team and see what they recommend. So the nice thing about using the arms as an exercise mode is that your exercises to your arms will always increase your heart rate a lot faster than exercises to your legs. For whatever reason. There are good reasons, but I'm not going to get into that right now. So doing things that engage your arms and use your muscles of your arms will elevate your heart rate nicely. So again, you can try and tailor the exercise or do something that engages your whole body, like a swimming exercise, or you can target your exercises to a particular part of the body, trying to elevate your heart that way. Again, recline bikes tend to be a little bit more protective than more weight-bearing exercises. Sustained positioning too, so you can find a position that is not placing strain on your joints, and just maintaining a sustained balanced position can sometimes be enough to elevate your heart rate as well. But do get some advice, specific tailored advice on the exercises that can engage that cardiovascular effect for you. Great question. Any others?
I'm not seeing any new ones, Susan, either.
Okay.
So I'd like to thank everyone for attending, and we will be making the recording of the session this evening available, as well as Susan's slides, and would like to thank everyone for your participation. But Susan, thank you so much.
Yes, my pleasure. Thank you so much for the invitation, Matthew, and thanks again to Bayer for sponsoring the event as well. Appreciate that.
Yes. Thanks, everyone, and good night.